All right, welcome back. See here a question. So the juxtamedullary nephrons are where the red line meets the blue pyramids, and they deposit urine into the pyramids. So the nephron, if you see on here, those are my cortical nephron. Above the junction is my cortex. All this part is the cortex. On here. This is the cortex that I've got here. So it has the cortical nephrons like this. And they have a very short part that travels down into the middle. Those are my cortical nephrons. Compared to the juxtamedullary nephrons, they still exist in the cortex. But at the junction between the cortex and the medulla, and they've got long loops of Henle traveling down like this into the pyramid. What else travels in the pyramid? If you see on here, we've got collecting ducts. So the pyramid itself is formed of those ducts, long loops of Henle of the juxtamedullary nephrons, and the collecting ducts collecting the urine down from multiple nephrons. And those are the lines we're drawing on here. The collecting ducts are the ones that will be conducting the urine towards the tip of the pyramid, towards the renal papilla. And from the tip of the pyramid, you're going to be conducting the urine into minor calyces, and then into major calyces, to the renal pelvis, and so on. Does this answer your question, Salak? Number 6 is a major calyx, yes. So what you've got here for number 1, what did you get for number 1 here? Cortex. How about number 2? All this deeper part of the kidney. Anyone else? Yeah, renal medulla, exactly. And how about this triangular shaped structure on here? Number 3, renal pyramid. And how about the tip of the pyramid? That serves as a connection between the pyramid and the minor calyx. Number 4, what you've got here, patella of the pyramid. And how about the small ducts that will carry the urine away from the pyramid? Number 5, this is going to be my minor calyx. And the larger ducts that will drain the urine from those minor calyces. Larger ducts, number 6, those are my major calyces. And how about this funnel-shaped tube? This funnel-shaped tube. This is my renal pelvis. And the muscular duct in here, this is going to be my ureter. All right, any questions? Any questions? So again, a quick reminder of the structure of the nephrons that we've seen before break. We've got here this cup-shaped tube. This is my glomerular capsule. And we've got sets of tubules on here. Those are my proximal convoluted tubules. Then we've got a tube that loops down. And then back up. This is going to be the loop of Henle. Then I have set of tubules located away from the Bowman's capsules. These are going to be my distal convoluted tubules. And finally, I've got the ducts that will be collecting the urine from multiple nephrons. Those are my collecting ducts. If we're looking on here at the blood vessels that will share in the formation of the nephron, I've got a tuft of capillaries that will be located inside the Bowman's capsules. This is the glomerulus. And I have another tuft of capillaries surrounding the proximal and distal convoluted tubules. Surrounding the convoluted tubules, so we call them, here are my peritubular capillaries. And I've got straight vessel that will be surrounding the loop of Henle. We call this is my vasa recta. All right, so let's focus first on the different capillaries. First is the glomerulus. The glomerulus, as you see, it gets its blood from the afferent arteriole and it drains the blood out through the afferent arteriole. The glomerulus is going to be responsible for the filtration of the blood. So if I'm telling you that the fluid is going to be traveling from the glomerulus to the Bowman's capsule, what do you think? Should I have a high or a low pressure within my glomerulus? Should I have high blood pressure or low blood pressure within the glomerulus? So I'm telling you that is going to be responsible to push out the fluid. If I have two sides, telling you that I'm pushing fluid from this side, from the glomerulus, into the Bowman's capsule. So would I have high pressure to push or low pressure to push? High pressure. So here the glomerulus has a high pressure, and this tells you why kidney, if you remember, why the kidney was it in height of high blood pressure or low blood pressure? Do you remember? Kidney, was it in height of the high blood pressure or the low blood pressure? It hates low blood pressure. Why? Because without having enough tissue perfusion, without having enough blood pressure coming in to the glomerulus, the kidney will not be performing the very first step of the urine formation, which is the filtration. So in order for the filtration to take place, I need to have high pressure. What allows me to create this high pressure? Two major factors. First factor is that the diameter of the afferent arteriole is much larger than the diameter of the efferent arteriole. So this means what? This means that the amount of blood that I'm getting in is larger than the amount I'm moving out. And this means what for me? This means that the difference between what I'm getting in and what I'm moving out is going to be filtered into the Bowman's capsule. So if this is the diameter of the afferent arteriole, let's say I am bringing in 50 milliliters. And here I'm draining out only 20 milliliters. What happened to the remaining part of the fluid? It simply gets filtered into the Bowman's capsule. So 30 milliliters on here are going to be passing from the glomerulus into the Bowman's capsule. This is the first factor, the difference in the diameter between the afferent and the efferent arteriole. And afferent arterioles are larger in diameter than the efferent arterioles. The second factor is that I'm connected to arterioles. And if you remember, the other name for arterioles are my resistance vessels. Those are vessels that will create a high resistance. And if you remember, high resistance means high pressure. You remember, mean arterial pressure is equal to cardiac output times peripheral resistance. So the higher the resistance, the higher the pressure. So here we're looking at a type of blood vessels with high resistance. This means it creates higher pressure, higher force by which the blood is going to be traveling in. High force of the blood. Moving on to the next type of capillaries. Those are my peritubular capillaries. And the peritubular capillaries are going to be surrounding my proximal and distal convoluted tubules. They are porous capillaries. They will be responsible for the absorption. So why would I need absorption in here? I did filter a lot of stuff from the blood into the Bowman's capsule. So now this filtrate is moving down in my kidney tubules. But not everything that I've filtered, I want to get rid of. So what would I need, for example, to do for the glucose that got filtered, for the amino acids that got filtered? I need them to move back to my blood. To give you an impression about the difference between the urine and the filtrates on here, you're gonna be filtering your plasma volume 60 times each day. So try to imagine all the plasma, every droplet of your plasma is gonna be filtered 60 times per day. So what is the average amount on here of filtrates that you're gonna be forming per day? What do you think? What is the amount that you're gonna be filtering each day? If I told you you have, let's say, 3 liters of plasma, and you're gonna be filtering this plasma 60 times per day. So what is the amount of filtrate that you're gonna be forming each day? What do you think? Around 180 liters. Are you releasing 180 liters of urine per day? What do you think? Are you releasing? Try to imagine you have a bottle. This is here. I'm not sure if you can see it here. This is half liter. Are you releasing urine equal to 360 bottles like this per day? You see here, I have 21 participants, only one who said no. How about the rest? How about the rest of you? No, you're not releasing 180 liters. So what you're gonna do with this filtrate, most of it get actually reabsorbed back from the kidney tubules to your blood. And 60% of the reabsorption is gonna be actually taking place in the proximal convoluted tubules, as they are surrounded by peritubular capillaries. So peritubular capillaries are allowing the reabsorption to take place in here. If I'm telling you I'm allowing reabsorption, I have the ability to reabsorb this large amount of fluid back to my blood. What do you think is the state of pressure in my peritubular capillaries? Do I have a high pressure or a low pressure? If this is my peritubular capillary in here, and this is my kidney tubule, proximal or distal, and I want to move fluid from the kidney tubule back to my blood. Do you want me to have a high pressure or a low pressure within my peritubular capillaries? High or low? What do you think? To get fluid back, would I have high pressure or low pressure? Try to imagine high pressure is pushing. Low pressure, suction. So which one would you like to have in the peritubular capillaries responsible for absorption? Low pressure, exactly. So in my peritubular capillaries, I will have low pressure, not high pressure. And what allows me to create this state of low pressure within my peritubular capillaries is simply that I am originating from the efferent arteriole. Remember, afferent arteriole that carry in 50 milliliters, let's say, because it has a large diameter. Compared to the efferent arteriole, it only carried out 20 milliliters. So here, the amount of blood that is traveling is much less than the amount of blood that came into the glomerulus. So having less blood into my peritubular capillaries is what allows me to create a state of low pressure within my peritubular capillaries, allowing the fluid to move back into my vessels from the kidney tubules. So imagine on here, drawing just Bowman's capsule. I got the blood in, I got 50 in, let's say, and draining 20 out. And those are my peritubular capillaries. Those are my tubules. So what is the pressure? If I'm saying that this is directly proportional with the pressure. So pressure here is 50, pressure here is 20. So what happened to the remaining amount of fluid? It got filtered on here. So what is the pressure inside my kidney tubules now? If I'm getting 50 and draining 20, so what is the pressure? It's 30. Just being a continuation of the efferent arteriole. Do I have, what is my pressure in the peritubular capillaries according to those numbers? In the peritubular capillaries, what is my pressure now? 20, like the peritubular capillaries. I'm a like the efferent arteriole. I'm a continuation of the efferent arteriole. So which one has a higher pressure? Your kidney tubules or the peritubular capillaries? What do you think? Tubules, they have 30, and in my peritubular capillaries, I have 20. So which one has higher pressure? 30 or 20? You see the question on here? Which one? 30. So this has a higher pressure. So the fluid's gonna be moving from high pressure in my kidney tubules to the side with lower pressure in my peritubular capillaries. So I'm allowing reabsorption to take place. So again, what we are discussing right now, we are discussing the characteristics of the peritubular capillaries. We mentioned that they are porous capillaries. They are adapted for absorption. And in order for the absorption to take place, I need to have a low pressure. What allows me to have this low pressure in my peritubular capillaries is that the peritubular capillaries are arising from my efferent arteriole. Those peritubular capillaries will later on, you see on here, drain into veins that will carry the blood back towards the renal vein, to the inferior vena cava, back to the heart. But they do not carry the blood away from the heart. They do not carry the blood back to the heart. They carry the blood still away from the heart. That's why we considered the vessel draining the glomerulus as an arteriole and not a venule. Moving on to the next type of capillaries that we do have as part of the nephron. This is gonna be the vasa recta. Again, what do I mean by vasa recta? Vasa means vessel and recta means straight. Those are the long vessels that will be surrounding the long loops of Henle. Can you remind me what type of nephron did have long loops of Henle? Cortical nephrons or the Juxta medullary nephrons did have long loops of Henle? You remember? Which type did have long loops of Henle? Are those the cortical nephrons or the Juxta medullary nephrons with long loops of Henle surrounded by vasa recta, Juxta medullary nephrons? So you'll see on here, vasa recta exists in the Juxta medullary nephrons because they are the ones with long loops of Henle. And if you remember, why did I have those long loops of Henle? To allow water reabsorption, free water reabsorption. I'm getting more water back from the kidney tubules to my blood. And this allowed me to create concentrated urine. So if I ask you, what is the function of the Juxta medullary nephrons? Form concentrated urine. What is the function of the long loops of Henle? Form concentrated urine. What is the function of the vasa recta surrounding the long loops of Henle? Form concentrated urine. So again, how the concentrated urine gets formed in the juxtamedullary nephrons. Juxtamedullary nephrons simply have long loops of Henle. And those long loops of Henle are surrounded by vasa recta. Vasa recta and the long loops of Henle allow more water to be reabsorbed back to the blood. And as I pull free water, not with solutes, just free water back, this allows me to concentrate the urine, reduce the size, and will have much more solutes in the urine than before, creating concentrated urine. All right, so for our next question for today, I believe it's question number 9. So what do you think is the functional unit of the kidney? This is question number 9 for today's in-class activity. What do you think is the functional unit of the kidney? Is it the ureter, the renal pelvis, the nephron, the minor calyx? Functional unit of the kidney is, any idea? Nephron. Nephron. Looking at the first step of the urine formation, we're looking here at the filtration. In order for us to understand how filtration takes place, we need to study the filtration membrane. Filtration membrane consists of part of the glomerulus, and part of my Bowman's capsule. So we're studying this membrane through which the fluid's gonna be filtered. Do you remember what type of capillaries did I have in the kidney back from the previous chapter? What kind of capillaries do you have in the kidney? Or can you please remind me of the 3 types of capillaries that we do have? What are the 3 types according to the structure of capillaries? We have continuous capillaries, we have fenestrated capillaries, and we've got the sinusoidal capillaries. If you remember, the most common type was the continuous capillaries, and this was the least permeable. The type of capillaries with the highest permeability, those were the sinusoidal capillaries, and the ones that would be allowing moderate amount of permeability, those were the fenestrated capillaries. And if you remember, fenestrated capillaries were located in the kidney, in small intestines, and in the endocrine glands. So again, what is the type of capillaries that we've got here in the kidney? Those are fenestrated capillaries. So looking here at the first part of my filtration membrane, it's formed of endothelial cells. You remember, capillaries are formed of one row of flat cells, endothelium. And those endothelial cells do have pores or fenestrations. Those are fenestrated capillaries. Those going to be sitting on a gel-like basement membrane. And on the other side, those are going to be the cells of the Bowman's capsule. Those are called my podocytes. And podocytes are cells with feet-like processes. We've got here cells, feet-like processes coming out. Those are the cells of the Bowman's capsule. So again, what am I looking at in here? I'm looking at the filtration membrane. And the filtration membrane is going to be formed of 3 layers. First layer that we're looking at in here, this is going to be my fenestrated endothelium. Fenestrated endothelium. Next is going to be the gel-like basement membrane. And this basement membrane contains positively charged proteins. The third layer are the podocytes of the Bowman's capsule. So 3 layers of my filtration membrane on here: fenestrated endothelium, gel-like basement membrane, and podocytes. So what can filter and what can't be filtered through this filtration membrane? The first thing that can't be filtered are my blood cells, because blood cells are larger than the fenestrations of the endothelium. If you remember, when we studied the 3 different types of capillaries last class, we mentioned that the type of capillaries that allows cells to travel in and out of the bloodstream, those were the sinusoidal capillaries, not the fenestrated capillaries. So fenestrated capillaries cannot allow blood cells to travel through. They are larger than the fenestrations in the endothelium. Another thing that won't get filtered are the positively charged plasma proteins. Plasma proteins are positively charged like the basement membrane. Basement membrane is also positively charged. So what would I have between the plasma proteins and the basement membrane? Would I have attraction or repulsion? What do you think? If both are positively charged, would I have attraction or repulsion in between? I would have repulsion. So as I try to filter the plasma proteins, they are positively charged, like the basement membranes, they will be pushed back into the blood, and this will prevent their filtration. So the first thing that won't get filtered are the blood cells. Second thing is going to be the plasma proteins. A third thing that won't get filtered are the macromolecules. Large chemical compounds can get filtered. Why? Because they are larger than the filtration slits between the feet of the podocytes. So if we're looking here, those are the podocytes, and those are the feet of the podocytes on here. You see, between the feet of the podocytes, I've got very, very narrow spaces. And those narrow spaces are what we call the filtration slits. Those filtration slits cannot accommodate large chemical compounds like the macro molecules on here. So simply speaking, what is the content of my filtrate? What do I have in the filtrate? What do I have in the filtrate? If I know that I can't allow blood cells, plasma proteins, and macromolecules from being filtered, what do I have in here on the other side of the membrane? What do I have? Everything except for those three. In other words, plasma minus proteins. So you do not just filter waste. I don't just filter uric acid. I don't just filter urea. I filter everything that I have in my blood except for blood cells, plasma proteins, and macromolecules. Unlike what you think that you only filter waste. Actually, everything gonna be filtered. Glucose gonna get filtered. Amino acids, all nutrients, sodium, everything, ions, acids, bases, everything gets filtered out. All right? Other than those three. Again, what are the three things that you do not filter across the filtration membrane normally? Blood cells, plasma proteins, and macromolecules. So the filtrate gonna contain everything that the plasma has without the protein. What is the plasma? This is the fluid where the blood cells are circulating. So filter everything besides what again? Other than blood cells, plasma proteins, and macromolecules. Those are the three things that won't get filtered normally. All right. If a person got fibrosis in here or destruction of the filtration membrane, at this point, a patient will develop an increase in, for example, plasma in proteins in the urine. We call this is proteinuria. It's not something normal to have protein in large amounts in the urine. It's not normal. It's not also normal to see blood in the urine. I don't see blood cells out in the urine. I don't see red blood cells. I don't see white blood cells. So those are not normally gonna get filtered. So what is again by definition is filtrate? What is the filtrate that I've got in here circulating within my kidney tubules? What is the filtrate? It's plasma minus proteins. Is this clear? Does this make sense? Questions? All right, so again, looking here at the filtration membrane. I've got three layers of the filtration membrane. I've got fenestrated endothelium of the glomerular capillaries. We've got the gel-like basement membrane, which is the lamina of the two basement membrane, one from the Bowman's capsule and one from the glomerular capillaries. And the third layer of the filtration membrane is going to be the podocytes, which will have food processes. And in between those food-like processes, we've got slits or filtration slits. So what we see on here, those are the glomerular capillaries, and surrounding the glomerular capillaries are the podocytes with their food processes. Those are the cells of my Bowman's capsule. If you notice on here, the endothelium of the glomerular capillaries is fenestrated. And those tiny spaces here between my food processes of the podocytes, those are my filtration slits. Again, what will be allowed through the filtration membrane is simply everything except for blood cells. They are larger than the fenestrations. Plasma proteins, because they are positively charged. I'm sorry here. I did mention it wrong. It's negatively charged. I'm sorry for this. So here, the plasma membrane protein is going to be negatively charged. I'm not sure why keep saying positive. Negatively charged, as well as the plasma proteins are negatively charged. So same exact concept on here. So negatively charged plasma proteins and negatively charged basement membrane. So I have repulsion between both of them. So negatively charged basement membrane, it's going to be repelling the plasma proteins that will have negative charge on them. Slit diaphragm or the filtration slits, those will repel my macromolecules. Macromolecules, those large chemical compounds, cannot pass through those filtration slits that exist between the feet of the podocytes. Looking here again at the three layers, those are the fenestrated endothelial cells, fenestrated endothelium. Then we've got the negatively charged basement membrane. Then we've got the podocytes with their food processes. Moving on to the structure of the different parts of the kidney tubules. Looking here at first the proximal convoluted tubules. Proximal convoluted tubules will have one row of cube-shaped cells lining the inside of the tube. I have simple cuboidal epithelium, and the simple cuboidal epithelial cells on here in the proximal convoluted tubules are going to have large number of microvilli. And if you remember, what are the microvilli? Those are finger-like processes coming out of the plasma membrane, and they are responsible to increase the surface area for absorption. Another characteristic of the cuboidal cells lining the proximal convoluted tubules is that they have large number of mitochondria. And if you remember, mitochondria are responsible for the generation of ATP, which is the form of energy that the cell is going to be dealing with. Proximal convoluted tubules are going to be mainly responsible for reabsorption. Moving on to the next portion of the kidney tubules, this is going to be the loop of Henle. The loop of Henle, as we mentioned, it has a descending limb and an ascending limb. The descending limb and part of the ascending limb are going to be formed by the thin segment of the loop of Henle. And the thin segment of the loop of Henle consists of just one row of flat cells. Why do I have one row of flat cells lining this thin segment of the loop of Henle? Simply to allow a minimal resistance against the reabsorption of the water back to my vasa recta. This is my vasa recta on here. To allow a minimal resistance against the movement of the fluid back to the blood, I will be lined only by one row of flat cells or simple squamous epithelium. Compared to the distal part of my ascending limb, the cells will be cuboidal to columnar in size. Moving on to the distal convoluted tubules. The distal convoluted tubules gonna also be aligned with simple cuboidal epithelium like the proximal convoluted tubules, but they have much less microvilli. The distal convoluted tubules are going to be more concerned with secretion. What secretion here? If I've got stuff that didn't get filtered, so they didn't pass in here, they are still remaining in my capillaries. They didn't get filtered in the glomerulus. They are still circulating in my blood. Would you like to keep them forever in your system? If you have got a medication and this drug was not filtered through the filtration membrane on here, it was, for example, attached to a plasma protein. So the plasma protein is negatively charged. It can't pass through the filtration membrane. So you're gonna keep, would you keep this drug forever in your system? What do you think? Would you like to keep it forever in your system? What do you think? No, right? So what you're gonna do with it, you're gonna simply throw it away. In mainly, what part is gonna be more concerned with secretion? It's gonna be my distal convoluted tubules. So again, which part is gonna be responsible for absorption? Which part of the kidney tubules is gonna be responsible for absorption? Proximal convoluted tubules or distal convoluted tubules? How about secretion? Which one is going to be responsible for secretion? Proximal convoluted tubules or distal convoluted tubules? All right, so actually, absorption going to be taking place in both proximal convoluted tubules and distal convoluted tubules. Secretion is the same. Takes place in both proximal convoluted tubules and distal convoluted tubules. But where do I mainly perform absorption is a proximal. Where do I mainly perform secretion is going to be in the distal convoluted tubules. So if I'm asking you a general question, where do I have absorption or where do I have secretion? It's gonna be simply both proximal and distal convoluted tubules. But if the question is more specific, who is mainly performing absorption, the answer now is going to be the proximal convoluted tubules. If the question is asking who's mainly performing secretion, the answer now is going to be distal convoluted tubules. But who is performing absorption? Both of them are performing absorption. And who's performing secretion? Both of them are performing secretion. But again, proximal convoluted tubules are mainly concerned with absorption, compared to the distal convoluted tubules are mainly concerned with secretion. All right, something to remind you of which one is responsible for which, or mainly responsible of which. So if you had got a check today, you've got money, glucose here. When do you think you're gonna cash it or deposit this check in your bank account? If you get it today, when would you deposit this check in your bank account? Right away, right? As soon as possible. So if I'm getting something back, I would take it as soon as I can. But when do you pay your bills? As soon as the bill is sent or on the due date? What do you think? Due date. Most of us will be paying just a day before the due date. So I wait until the very last days to pay. If I'm getting something out, I wait until the end. I'm getting something in, I get it in as soon as I can. All right, so again, if I'm absorbing, who's gonna be mainly performing absorption again? The one close or the one far from the Bowman's capsule? The one close to the Bowman's capsule, proximal convoluted tubules. And when I'm getting something out, remember, paying your bills, you're gonna wait until you get to the distal convoluted tubules. All right, make sense? Make sense? So again, what is the structure of the cells of my proximal convoluted tubules? They are cuboidal cells. They have dense microvilli and large number of mitochondria. Function is absorption and secretion. Remember, mainly reabsorption. I'm performing most of the reabsorption is taking place in the proximal convoluted tubules. As we're gonna see next class, it's gonna be performing reabsorption of 60% of the water just in the proximal convoluted tubules. We'll be moving back in the proximal convoluted tubules. They are confined to the cortex. If you remember, here in both the juxta medullary nephrons and the cortical nephrons got their proximal and distal convoluted tubules in the cortex. So proximal convoluted tubules are going to be confined to the renal cortex. Loop of Henle, again, I have two segments, a thin segment and a thick segment. Thin segment is going to be in the descending limb. It's going to be formed of simple squamous epithelium, just one row of flat cells, as you see on here, And this one row of flat cells is going to be creating a very minimal resistance, which I need to allow free water reabsorption. I am highly permeable for the water to travel. So water will travel without the need of moving salt, free water. Compared to the thick segment, it's going to be formed of cuboidal to columnar cells, and it's going to be confined mainly to the ascending limb of the loop of Henle. Moving on to the distal convoluted tubules. Distal convoluted tubules are going to be formed of cuboidal cells, but remember they have few microvilli, much less microvilli than what I did have in the proximal convoluted tubules. The function more in secretion than reabsorption, but they still perform some reabsorption. But mainly they are concerned with secretion. And again, they are confined to the renal cortex. In both juxta medullary nephrons or cortical nephrons, proximal and distal convoluted tubules are confined to the renal cortex. Last part of my kidney tubules, those are the collecting ducts, and they will be responsible to receive the filtrate from many nephrons. And this is where I've got the name. They are ducts who are collecting here the filtrate from multiple nephrons. They will fuse together and will conduct the urine through the papilla of the renal pyramid. Then this urine is going to be conducted to minor calyces, major calyces, renal pelvis, ureter, and so on. Are we saying the peritubular capillaries? I've got a question here. Are we saying that the peritubular capillaries reabsorb water as a proximal convoluted tubule, or that the actual proximal convoluted tubule absorbs water? So it's something like this here. We're going to get to the details of the absorption and secretion in our next sessions. But generally speaking, so you have a lumen on here. This is of the kidney tubule, proximal or distal convoluted tubule. And I've got a blood vessel running parallel to it. This is my peritubular capillary. So in order for me to absorb, what do I need? I need to travel through a cell. Like this. The cells lining my membrane. And those cells are going to be connected to the fluid on this side and the fluid on this side. So I have two sides. Fluid in the peritubular capillary is the blood. And the fluid in the proximal and distal convoluted tubules, this is going to be my filtrate. And I will be performing the absorption or secretion according to the concentrations on both sides and the hydrostatic pressure. So I have many factors that will be determining whether a substance is going to be moving in this direction or in the opposite direction, or there will be no movement at all for the specific substance. All right, so in order to allow reabsorption to take place of, generally speaking, any substance, what I need to have in the peritubular capillaries is low pressure. Why? Because if I did have a high pressure, high hydrostatic pressure, this is going to be pushing everything, preventing everything from being reabsorbed. Having too high hydrostatic pressure is going to definitely be preventing any reabsorption of any kind. Because if you did allow something inside the cell, let's say glucose, I allowed the glucose inside the cell. Where is glucose going to go next? It's going to move to the blood. If I don't have, or if I have very high glucose level here in the blood, too high, will this glucose be transported? No, it can't move from its low pressure to its high pressure within the blood. So it's going to remain in the cell. Can I get another glucose from outside in this condition if I have too much glucose inside the cell? No. So I will not be moving any more glucose to the inside of the cell and then to my blood as a result. So generally speaking, what do I need? I need many things to carry on the secretion and the reabsorption. And those things are going to be different according to what you actually are willing to transport across the membrane. Does this make sense? So did this answer your question? So isn't the proximal technically secreting back into the blood vessel? So proximal convoluted tubules and distal convoluted tubules are going to be performing both secretion and reabsorption. But in the proximal convoluted tubules, I have much more reabsorption taking place. So let me pull up an example on here for you. This is just an example. You don't have to worry about it. So look in here. This is a lumen. Where I keep the filtrate. This is where I keep the filtrates that will become urine. I want to transport from the lumen, where I've got the urine, sodium, let's say, to my blood. So I should have a carrier to transport this sodium. On the surface of the cell, this is my cuboidal cell on the proximal convoluted tubule. This is just one cell. So I should have a carrier to allow the transport of the sodium along with glucose. If you wanted to transport the glucose from the urine back to your blood. And on the other side of the cell, on the basal side of the cell, I will need to have another carrier for me to reduce the sodium concentration within the cell by releasing the sodium back to the blood and getting instead of it potassium. So in order for me to get the glucose, what did I need to have? I need to have a carrier, that allows both sodium and glucose to travel from the lumen to the cell. And I need all the time to keep low sodium concentration. Why should I keep low sodium concentration within the cell on here? Because simply, if I have high sodium, this carrier will not function anymore. If I do have high sodium concentration within the cell, this carrier cannot transport any more sodium to the inside of the cell. So the transport of both the sodium and the glucose will stop. So what allows me to keep low sodium concentration within the cell is the exchange that takes place this time at the basal side of the cell with the blood. So I carry potassium from the blood to the cell in exchange of sodium. Why? Because I have too much sodium outside of the cell. So I need an active membrane transport to carry the sodium against the concentration gradient. And this is what we've called, if you remember back from AP1, the sodium potassium ATPase pump. So I carry the sodium from the cell to the outside of the cell to keep this sodium inside the cell at low concentrations to keep allowing the sodium to travel in from the urine or the filtrate. All right. What if I do have very high hydrostatic pressure in here? I have very high hydrostatic pressure in the interstitium. So the fluid itself will not be transported. This is going to be reducing the ability of everything from moving back to the blood. Everything, because there are two major pressures that we should be putting into consideration. One is going to be the hydrostatic pressure. What is the hydrostatic pressure? The hydrostatic pressure is simply the weight of the fluid. This is one effective pressure. The other type of pressure that we're dealing with here is osmotic pressure. What is the difference? If I have a tube like this, on this side, I'm not adding any water. On this side, I'm adding 5 liters of water. And both tubes are connected, as you see. The water will not remain here only. It will move to the side with high hydrostatic pressure to the side with lower hydrostatic pressure until I have equal pressure on both sides. So what did drive the water to travel is the weight of the water itself. This is what we call hydrostatic pressure. This is what I am reducing in the peritubular capillaries, getting the blood in the peritubular capillaries from the efferent arteriole. This is the pressure I'm talking about, hydrostatic pressure. It's determined by the weight of the water. The other pressure is not determined by the weight of water, it's determined by the concentration of solutes. So if I have the same amount of water on both sides and I've got a membrane in between those two tubes, but one side has much more solutes, what's going to happen? By osmosis, and the definition of osmosis is the movement of water from the side with low solute concentration to the side with high solute concentration. So here, the water is dragged to the side with higher solutes. This is what we call osmotic pressure. And those are two different effective pressures that will contribute in the transport of fluid in and out. So in the glomerulus, what allowed the filtration to take place is actually that I have very high hydrostatic pressure. And this high hydrostatic pressure is created by what? Is created by the tissue perfusion. And remember, tissue perfusion is determined according to your mean arterial pressure. So actually the pressures that allows the filtration to take place in here is mainly, not only, mainly the hydrostatic pressure created by the blood vessels, all right, which is going to be systolic, diastolic pressure in the vessels. This is what's going to be determining the tissue perfusion, and the tissue perfusion is what determines the hydrostatic pressure that drives this fluid out. So you see many contributing factors on here. All right. Does this give you a better idea of what we're talking about here? Yes. You're welcome. Thank you. All right, so looking here at the mechanism of urine formation, every droplet of plasma gets filtered 60 times per day. 60 times per day. Filtrate, if you remember, is plasma minus proteins. Why plasma minus proteins? Because simply proteins are negatively charged, like the negatively charged basement membrane of the filtration membrane. So I have repulsion between the plasma proteins and my negatively charged basement membrane. This repulsion will prevent the plasma proteins from being filtered. So it's not, they are not going to be part of the filtrates that you're going to form. Compared to the urine, urine is representing less than 1% of the total filtrate. Remember those 180 liters that you filter per day? You're not releasing any number close to this as urine. Let's say we'll be releasing half liter or 1 liter of urine per day. So 1 over 180 is much less than 1%, almost 0.5% even. So urine is representing less than 1% of the total filtrate that traveled from the glomerulus to the Bowman's capsule. This 1% or less than 1% of the filtrate gonna contain most of the metabolic waste and the unneeded substance. So we're looking here at just 1% of the filtrate, but it contains most of the metabolic waste, most of the unneeded substance. 3 steps of the urine formation. Again, first is going to be the glomerular filtration. And again, what is the main driving force for glomerular filtration? It's the hydrostatic pressure. And again, what created this hydrostatic pressure, this high hydrostatic pressure within the glomerulus? Again, why do I have high hydrostatic pressure? Because the afferent arteriole is much larger than the efferent arteriole. So the amount of blood that moves into the glomerulus is greater than the amount of blood that will be drained out of the glomerulus. Another thing that those are arterioles, they are high resistance vessels. So having high resistance creates greater hydrostatic pressure. The force of water of the fluid moving in here is going to be driving the fluid out of the glomerular vessels into the Bowman's capsule. And the second step of the urine formation is going to be the tubular reabsorption, where I would be recollecting any filtered glucose, amino acids. I would be recollecting 99% of the water that gets filtered, salt, and other components of the blood. Third step is going to be the tubular secretion, which is a reverse of the reabsorption, which I have selective addition to the urine. I will look back at the blood and I will see if I still have a metabolic waste or a toxin or a metabolite that I don't need anymore. What will I do? I will simply release it out in the urine. And again, mainly I'm concerned with what is the part of the kidney tubules that is mainly concerned with secretion. It's going to be your distal convoluted tubule. Again, this diagram is showing the 3 steps of the urine formation. First step is the glomerular filtration. Next is going to be tubular reabsorption, and finally is going to be the tubular secretion. Questions? All right, so let's have another important diagram as a class activity for you to complete. All right, so this diagram is showing the nephron and the different kidney tubules and the capillaries that will be sharing in the formation of the nephron. So the last one was number 9, so let's this be 10. Yeah. All right, so today we've got 19 questions for the in-class activities.